So thank you again, everybody, for joining the Nierman Practice Management Tuesday evening webinar. We have a great topic in store for this evening. We have Dr. Jagdeep Bijwadia here with us to talk about the physician and dentist collaboration relationship. So he's going to be sharing some tips on that. Just a quick background on Dr. Bijwadia. He is the founder and CEO of SleepMed RX. He is board certified in internal medicine, pulmonary medicine, as well as sleep medicine. So we've got a triple threat here. Prior to starting his own practice in Minnesota, he did serve as the attending physician at Health Partners Medical Group, and he was the department head and director of the Sleep Medicine Center. So with that, he's a great speaker for this topic, and he does currently hold a faculty position as the assistant professor in the Department of Pulmonary Critical Care and Sleep Medicine at the University of Minnesota, where he served as director of the sleep program up until 2012. Not only that, he's completed the executive MBA program at the University of St. Thomas in Minneapolis, as well as named top doc by the Minneapolis Magazine, U.S. News and World Report. So super excited to have him on with us this evening. He's also recently served as president of the Minnesota Sleep Society. And again, Sleep Medicine RX is designed to enhance the collaboration between dentist and physician, which he is the founder of. So thank you very much, Dr. Bijwadia, for taking the time to share your expertise with us, and we're looking forward to it.
Absolutely. Thank you, Courtney, and I hope everybody can hear me well. I'd like to thank John and Rose and Courtney for inviting me, Nierman Practice Management. This is a topic that, quite honestly, is very near and dear to my heart because a long time ago, I was diagnosed with REM-related sleep apnea myself. I'm not particularly overweight or anything, but it's such a common disease, and I found myself being a little bit more fatigued than I like to think of, and I really couldn't tolerate CPAP, and felt a little bit sheepish about telling my patients to wear CPAP, and ultimately I did get into a dental device that I still use. And so it's always struck me that physicians and dentists should really be collaborating more often because so many patients don't tolerate the standard treatment, and we'll talk about that in a little bit more detail and ways in which I think dentists in my area have collaborated with me. And one of the things I should mention is that I have been very involved with the dental sleep space for a number of years as Chief Medical Officer of SomnoMed, which I no longer hold that position, but I had the chance to interact with a lot of dentists as well as a lot of physicians who are often quite resistant to the idea, at least initially, although things seem to be slowly changing for the better. So in terms of my conflicts of interest, I am CEO of SleepMed RX, which is really a telemedicine company. And I won't be talking too much about that, but it is a way for dentists to interact with physicians in a pretty easy fashion. Currently, I'm Chief Medical Officer of Better, which is a screening device for sleep apnea, and I have just one slide about that, only because it's a sort of a new and innovative form of screening that I think it's important to be aware of. But those are my conflicts. I thought I would work this topic by first going over a very brief review of what obstructive sleep apnea is. And I recognize I'm probably talking to a pretty sophisticated audience here, but it never hurts to do a little refresher on what sleep apnea is so that all of us start off on the same page. We'll talk a little bit about the epidemiology and prevalence, some of the evidence that is important in terms of support for using oral appliances in the treatment of sleep apnea. And then we'll go on to the main topic, which is, ideas of how we can improve dentist and physician collaboration just across the field. So I think most of you are familiar with obstructive sleep apnea, which is a disorder characterized by the recurrent collapse of the pharyngeal airway during sleep, despite efforts to continue breathing. And so this leads to drops in oxygen levels or derangements in blood gas, surges of sympathetic activation as our brains sort of react to the sudden hypoxemia, and periodic arousals from sleep that cause sleep fragmentation and subsequent fatigue and sleepiness during the day. And this is a pictorial of a patent airway on the left and a collapsed airway on the right as the tongue and soft tissues move backwards into the airway to obstruct the airflow. If you look at a polysomnogram and look at the airflow, you can see that the patient is inhaling and exhaling, and then suddenly the airway obstructs. So, the patient then starts to breathe more and more forcefully in an effort to open that airway. The abdomen and chest may paradox or move in opposite direction. And finally, the airway opens, which you can see towards the end of the slide, and the paradoxing ends. But by then, if you look at the red arrow in the bottom, blood oxygen levels often drop. And if they drop more than 4%, if you think about Medicare criteria, or 3% if it's commercial, basically once the oxygen level drops, the airway tends to open up again with an arousal, and the whole cycle can start multiple times. So this is what we actually look for when we're reading sleep studies, whether they be home sleep tests or polysomnograms. So it's this particular cycle of events that is fairly obvious in severe cases. The common symptoms of sleep apnea are certainly snoring, and I would say about 90% of patients who present with obstructive sleep apnea snore, sometimes so loudly as to cross OSHA standards of safety, actually. The patients often have observed apnea or pauses in breathing. The patients themselves may not be very aware of this, and therefore it's quite important for us to interview the bed partner. And I always encourage my patients to bring in their spouses or partners, although oftentimes they're at our office at their behest. The patient may experience some gasping type arousals at the end of apnea. This results in multiple nocturnal awakenings. Patient may urinate frequently. I often tell patients that remember that an enlarged prostate and diabetes is not the only cause for somebody waking up frequently to urinate at night. And it's quite gratifying to treat sleep apnea and see the patients do so much better afterwards. I think one of the most common symptoms that patients present with is excessive daytime sleepiness. And this can obviously affect their daily activities, their ability to drive, and even their ability to stay awake at work. They often wake up with dry mouth in the morning. Certainly headaches are common, and irritability and depression as well. And oftentimes after treating sleep apnea, the patient's spouse often comes back and says, God, I can finally live with my spouse now because they're so much easier to deal with. I think all of you know that when a patient opens their mouth, we can recognize what's called the Mallampati score. And as the score goes from class 1 to class 4, the risk for obstructive sleep apnea tends to increase linearly across that line. The pictures at the bottom show an enlarged furrowed tongue with the furrows on the side that indicate that the tongue is probably too large for the patient's airway and can easily fall back. There's teeth grinding or bruxism that can cause teeth wear and tear. It's one of the signs of obstructive sleep apnea. And then overbite that tends to push the mandible backwards and predispose to airway collapse as well. And this, of course, I'm not going into the details of the symptoms and physical exam just because this is more of a quick review of obstructive sleep apnea. So once we suspect that a patient has obstructive sleep apnea, there are some pretty easy ways to make a diagnosis nowadays. Typically, when we screen patients for the disease, it's usually in the form of questionnaires. The Epworth Sleepiness Scale score is a common one, which is a scale from 1 to 10. And anything greater than 10 indicates that the patient is generally more sleepy than normal. And it shouldn't give us some risk for obstructive sleep apnea. There are also other simple questionnaires like the Berlin questionnaire, and I have no doubt that many of you probably use some of these questionnaires in your practices to easily identify these patients. Ultimately, once you think that a patient is at risk for sleep apnea, a sleep study is generally needed to objectively confirm the diagnosis, and this can be done either in the home sleep test, home setting. So for example, on the lower picture, you can see somebody with a WatchPat device that has a little finger probe and a wrist band that is able to monitor the patient's peripheral arterial tonometry and indirectly measure the patient's obstructive apnea index. There's also other devices, some that go on the forehead, like CleaveMed. There's ones that have effort belts, like in the third panel there, with a nasal cannula that can measure oxygen flow. And then lastly, of course, there is the full polysomnography that includes brain waves, multiple leads for airflow, as well as effort and leg bands, video monitoring, the whole 9 yards. Recently, there are some interesting ways that screening has evolved. All of you are probably aware of the various wearables that are available now, including the iWatch and the Fitbit and things like that. But none of them really were able so far to accurately predict obstructive sleep apnea specifically. They tell you a little bit about the quality of sleep and maybe the sleep stages, but not so much whether the patient's at risk for sleep apnea. This device, called a better device, actually sits on the forehead. It's sort of like a postage stamp sized little device, and it measures what's called stop breathing events by measuring pulse oximetry on the forehead. And it's a pretty neat little device, and also gives the patient some tips and tricks for sleep hygiene as well. So this is currently available on the market, and it's the only one that I know that actually screens for obstructive sleep apnea, although it's not FDA approved for that particular indication. But it is pretty accurate, and this is a company that I am helping to take forward in terms of the next evolution of this product. On the right-hand side is another interesting evolution of the home sleep test. And you can see here that this little device that sits on the tip of your finger and is connected to an app can tell us about the patient's AHI. And it's a cloud-based device. It can be used multiple times. And especially for dental practices, I think it will be extremely useful to continue monitoring the patient as the patient's device is titrated forward, allowing for multiple measurements and effective titration. But I thought I would just highlight some of these newer, and by the way, the EctoSense is not yet available on the market, so before you ask, it is in Europe, but it's undergoing FDA approval right now. So, of course, most patients are pretty petrified of going into a sleep center, and I think home sleep testing is surely taking over in terms of the preferred method for diagnosis, at least for the uncomplicated cases. Why do we worry about sleep apnea? Of course, there are multiple complications, including heart attack, stroke, memory loss, diabetes, depression, hypertension, drowsiness, all of which can be improved with effective treatment of obstructive sleep apnea. So I think when you are seeing patients in your dental office, there is a absolutely huge impact that you can make in their lives by identifying this problem and effectively managing it. The costs associated with untreated sleep apnea are not trivial. And I think it's important to note that the economic burden of neglecting care for sleep apnea significantly outweighs the cost for diagnosing and treating the condition. So currently it is estimated that about 80% of patients with obstructive sleep apnea fall into the undiagnosed category. And this is a slide that is taken from the American Academy of Sleep Medicine that commissioned a study with a company called Frost & Sullivan, which is a financial analysis company. And they estimated that the prevalence of sleep apnea is about 12%, as you can see above. About 80% of them are undiagnosed. Interestingly, about 85% go on CPAP, and just about 10%, and probably is fairly accurate. I would say somewhere between 5 and 10% of patients in the United States end up on oral appliances. An even smaller minority go on to surgery. And almost all of them should be having some lifestyle changes, for example, sleeping on their side or losing weight. It is important to note that of the 85% that were treated with CPAP, there's a significant non-compliant population, which is estimated at least 40% and probably significantly more. So I think all of us are pretty familiar with the two most common treatment options for obstructive sleep apnea, CPAP on the left-hand side tends to pressurize the airway and lift the tongue gently forward. And as long as the CPAP is on the patient's face and the seal is good, you should be able to open up the patient's airway. A dental device obviously works by moving the mandible forward. That moves the tongue and soft tissues with it. It alters the physiology and anatomy of the upper airway and results in improved airflow and elimination of the obstructive sleep apnea. So fairly different mechanisms of action, but both can be very effective. This is a slide that I lifted from David White, who was the editor of the Sleep magazine and a professor at Harvard for quite some time. And his comment was that in the United States, it seems that once you're diagnosed with obstructive sleep apnea, the standard of care is to place the patient on CPAP. And then if the CPAP fails, you go from fixed to an auto, and then you continue trying it over weeks or months. And if the patient fails, you just keep trying until the patient fails and is lost to follow-up. And this is, unfortunately, it is the state of affairs in just too many offices, and I think it's high time that we change this paradigm. Of course, CPAP, when it is used and has a good seal and the patient can tolerate it, is a very effective therapy. But I think this study amplifies how significant a problem compliance is. And this was a study done by Loretta Colvin-Adams, who looked at commercial motor vehicle drivers. And it's important to note that these drivers had their livelihood dependent on the fact that they would be compliant with CPAP. There isn't a more motivated population that I can think of. These patients were monitored on a daily basis. And you can see in the chart on the left-hand side that within a year, less than 60% of patients remained adherent. And this is with objective monitoring. And furthermore, if you took into account the patients that were actually lost to follow-up as well, then the percentage actually falls to about 40%. So this, I think, is a real-world example of patients who are extremely motivated, presumably, to use their therapy, and yet the compliance rates are rather dismal. So when we do choose treatment, whether you're a physician, a dentist, a patient, there are a number of factors that affect our choice of treatment. Of course, the effectiveness of a particular therapy is very important, and we want whatever therapy we choose to be able to improve the patient's condition. But then there are other things like patient preference, which we don't take into account often enough. We should be worried about the health outcomes. Once we treat a patient's obstructive sleep apnea, what is the evidence that that particular treatment is helpful for the patient's health outcomes like hypertension or cardiovascular disease? What is the cost of the treatment? How do your peers or the patient's peers feel about it in terms of their recommendation? What is the personal experience of the patient once he's on therapy? What kind of side effects and complications are they experiencing? What is the competency of the treating physician? Does he know enough about dental devices? Or does a dentist know enough about the contrary therapies or the alternative therapies that are available? And lastly, the patient's time commitment and the ease of use, or just the hassle factor with treatment that sometimes can get in the way of effective treatment long term. So getting to sort of the meat of the topic today is, given all of this, we've got some background information now about what sleep apnea is, how we diagnose it, what the factors are, and we know that alternative therapies are important. But how do you change a physician's behavior who seems to be, I'll say, stuck on the single therapy of CPAP? Or even if they use dental devices, probably they aren't as open or friendly to dental devices as they potentially could be. And again, I must admit that the landscape is changing today, and the more I talk to physicians and more evidence mounts, these things are going in the right direction. However, obviously a lot more can be done. So as a dentist, how do you change a physician's behavior and get them to be more confident in referring patients to you and working well? So the first thing I would say is that you absolutely need to know the subject of dental sleep medicine well and anticipate questions that a skeptical physician might have. Because if a physician feels that you're knowledgeable and able to respond to questions in a effective and intelligent way, I think they're much more likely to work with you and recognize that, yes, you're not only fitting a patient's dental device, but you're committed to the field of sleep medicine and understand the importance of follow-up and management. And so, as a corollary to that, it is important to be familiar and have supportive data when objections come by. So if the physician says, well, I don't really believe that the devices are effective, how do you counter that? What kind of evidence, can we show them, or what arguments can we present to them? And so I thought maybe it would be interesting for us to think about where the skepticism arises and how we could potentially respond to those particular questions. And I thought of 5 broad areas that we could think about. One would be, physicians often feel that dental devices aren't effective, right? So how do we have a conversation about that? What about patient preference? I think most of us would agree that dental devices are generally preferred, but is there any evidence to back that up? What about health outcomes? When we compare CPAP and dental devices, are they similar health outcomes, or are there areas where CPAP is definitely superior? And I think that knowing the literature and understanding how to interpret studies coming out is important. Physicians often have questions about the safety of dental devices and say, oh my God, you're going to mess up the patient's temporomandibular joint and their bite changes. And so what is the evidence that dental devices are safe? And lastly, what about the economics of it? If you compare CPAP and dental devices, is there an argument to be made on the economic front? So let's take each one of these for a bit and start parsing them out. So when we talk about the efficacy of oral appliances, I think it is important for us to recognize that many of the studies don't really define what efficacy is very well. Some of the studies talk about reducing the AHI to less than 5. Others say, well, it's effective if the AHI is less than 10. Yet more studies say that, well, if I can show a 50% reduction in AHI from its baseline, well, I would consider that effective. And so depending on the type of definition you use, you're going to get a different percentage efficacy for oral appliances. And then again, if you think about mild, moderate, and severe sleep apnea, certainly oral appliances are more effective in the milder range. And as the patients have more and more severe sleep apnea, there seem to be patients that tend to not respond. Although I will point out that even with severe sleep apnea, there are patients that respond beautifully to sleep apnea. And I think that the ongoing area of research is how do we identify those patients who have moderate or even severe sleep apnea that might be good candidates for a dental device. But be that as it may, I think it's fair. It's a fair criticism to say that oral appliances have more variability in their individual response compared to CPAP. I think that's a fairly fair statement. So how do you counter that? I think this study by Peter Sestouli is extremely instructive. And what it says is that when we talk about efficacy, we're really talking about a single dimension, which is how low does the patient's AHI fall after going on a particular treatment, whether it be CPAP or an oral appliance. And if you're looking just at the AHI over a period of time, then certainly CPAP has a significantly more argument for efficacy. But effectiveness is really how something works in the real world. We know that patients with CPAP don't have a high compliance rate. We also know that patients with CPAP, when they're not compliant, often take the CPAP off in the middle of the night. And guess when your sleep apnea is at its worst? Well, it's in the early morning when you go into REM sleep, right? So if you're protected half the night and not protected the second half of the night, well, wouldn't it be better to have an oral appliance that's maybe 75% effective or 80% effective, but the patient is using it all night? So in this particular diagram, you can see that if you take both efficacy and compliance into account, then the outcomes and the effectiveness of oral appliances is very much similar to CPAP. And how do we go about talking about compliance with physicians? Well, in the past, CPAP was the only therapy that allowed objective compliance monitoring. most of the compliance statements for oral appliances were based on subjective reports. But now, of course, there are small monitors that we can put within the dental devices, sensors that sense the temperature change and the change in body position while the dental device is in. And therefore, we can now look at evidence-based studies that show that if you think about the compliance with oral appliances, the average use was 6.4 plus minus 1.7 hours per night, which is significantly more than any of the CPAP studies can point to. So I think that we can point to the fact that oral appliances are more compliant with patients, and that we have objective data to actually prove this. So I think when we talk about physicians in regards to effectiveness, I think we can point out that, look, there's really strong data and guidelines to support use of oral appliance therapy in mild to moderate sleep apnea. And I think it's very important to consider both a reduction in the apnea index, AHI, as well as compliance when you think about reflectors of clinical outcomes. And lastly, given the cost and the individual variability, I'll say, a response indicator for patients who have severe sleep apnea would certainly add confidence going forward in the future. And there are certainly strides being made in this particular area. So let's talk about the next area of maybe some skepticism, which is patient preference. And physicians might say, well, I don't really think that dental devices are preferred. I think my patients really love their CPAP, and I have a 95% compliance rate. You know, I can't tell you how many times I've heard that from my physician colleagues. Well, I think if you think about the patient preference and in terms of evidence to support that, some of the best evidence comes from Fernanda Almeida out of British Columbia. And one of the things she points out is that when we choose a particular therapy in terms of preference, the patient expectations and factors that impact treatment choice are often ones that we may not be considering as we're prescribing therapy. So for example, if somebody comes into your office with obstructive sleep apnea, how often do we think about the bed partner benefits, or whether the patient is worried about transportability, or if they're young, whether the treatment might be embarrassing if they have a date over? These are things that can significantly impact the patient's choice and compliance with therapy. And so one of the things she said is, well, let me do a study to figure out whether we can objectively prove that patients prefer their oral appliance therapy over CPAP. And this was a rather cleverly designed study. What she did was she took patients with moderate to severe sleep apnea who were extremely compliant with their CPAP. They had been on it for months and had demonstrated excellent compliance. And she measured the Epworth Sleepiness Scale and S-QoLi, which is the quality of life index, the sleep-adjusted quality of life index, to be precise. So she looked at those parameters and she says, well, we're going to take these patients who are extremely compliant with their CPAP, and we're going to switch them to a mandibular appliance splint, as they call it, advancement splint in Canada it's called. So we're going to switch these patients who are very compliant with CPAP to dental devices, and now do a follow-up polysomnogram, see what their apnea index is, and then disclose that to the patient. And then we'll see which one they prefer. And you can see here that in patients who used mandibular appliance splints, their Epworth Sleepiness Scale scores actually fell a little bit more than with CPAP, although there was not any particular statistical difference. The same thing with the sleep-adjusted quality of life. So at least in terms of sleepiness and quality of life, both therapies seem to be equally effective. It was clear that CPAP actually did improve the AHI more than mandibular appliances in this study. And the patients were aware of this when they gave their final survey. So this study was trying to understand what are the trade-offs that patients are willing to make regarding the benefits and risks of treatment. So as a physician looking at the AHI, I'm going to clearly say that, hey, this patient should stay on CPAP, right? Because their AHI fell more than it did with CPAP, with the mandibular appliance, and it was statistically significant. But interestingly, if you ask the patients, a significant portion, 55% of the patients, even despite knowing that CPAP reduced their AHI more, still preferred the mandibular appliance splint. And even more interesting, if you ask the bed partner preference, 85% of the patients said, well, hey, I would rather have my partner treated with a dental appliance rather than CPAP. So this is, I think, good evidence to show that indeed mandibular appliances are preferred by patients. What about health outcomes? I'll spend a little bit more time on this because it's an important aspect. I think one of the key reasons for treating obstructive sleep apnea is to prevent future problems, which include hypertension, cardiovascular mortality, cardiac autonomic function, endothelial function, driving. All of these are outcomes that are extremely important for the treating clinician, right? And we know, we've already talked about the fact that CPAP has a lower compliance, but higher efficacy. But if we take both of those factors into account, could it be possible that the health outcomes for both CPAP and oral appliances might be similar? And there is evidence actually to support that. Here's a combination of studies that have looked at the efficacy and effectiveness of oral appliances versus CPAP. And in almost all of these studies, you can see that the baseline AHI generally falls more with CPAP than an oral appliance. However, if you look at the health outcomes, including daytime sleepiness, health-related quality of life, and blood pressure, there's really not much difference between any of the treatments. So that is one piece of evidence. A more compelling argument can be made for hypertension. And this was a very recent meta-analysis done by Bratton, reported in the Journal of JAMA. And here he looked at all of the studies that had been done to date, which were evidence-based and randomized, looking at both CPAP and mandibular advancement device, and asked the question, hey, if I looked at just hypertension as the outcome, which of the particular treatments is more effective? And these are forest plots for both the studies. And I don't know if you can see my pointer, but hopefully you can. You can see here that if you compare CPAP with a mandibular advancement device here, this is the line of equality. That means if you see a circle or a diamond within this line, that means there's no benefit of one versus the other. And you can see that both CPAP and mandibular appliances fall onto that line. And so the conclusion of this study, of course, is that at least in terms of hypertension, there is no advantage that CPAP has over mandibular appliances, and the outcomes are exactly the same. This is a study of other health outcomes done by Dr. Peter Sistuli, which was reported in the Journal of Respiratory and Critical Care about 3 years ago, I think. And here, what they did was they took patients, in fact, 177 patients, and then randomized them to either CPAP treatment or mandibular appliances. And then they entered what's called a treatment phase, and then they did a crossover. So all of the patients that were initially on CPAP went to a dental device. All of the patients that were initially in a dental device went to CPAP. So this was a very rigorously done study. And you can see that 82% of the patients in this particular study had moderate to severe sleep apnea. So these were not just mild apneics. These were patients with significant disease, right? And what he said is, well, I'm going to check at the end of the study period what happened to their AHI, their compliance, their 24-hour blood pressure, their neurocognitive function, including driving simulators. So he made each one of their patients go through driving simulation before and after treatment. And of course, the quality of life and arterial stiffness, which is a surrogate marker for cardiovascular mortality. So these are a number of important health outcomes compared head-to-head in this study with CPAP and a dental device. And as expected, CPAP did reduce the AHI more than a mandibular appliance, so 4.5 versus 11.1. And also, as expected, the patients were more compliant with a dental device, so 6.5 hours versus 5.2 hours. And the question, of course, is, does one offset the other? And this is the data regarding the mean Epworth sleepiness scale. This is the patients when they had a baseline of 9.1. Then they had an acclimatization washout, which is just where they have no treatment at all, so they're still at 9.2. Then they go down to 7.4 with CPAP. Then you stop CPAP and put them back on no treatment at all. It goes back up to 9, and you put them on a dental device, and lo and behold, it goes down again to 7. And there was no statistical difference here between CPAP and a mandibular appliance. But interestingly, whether you looked at the driving performance, whether you looked at quality of life, or if you looked at blood pressure control, all of these outcomes were exactly similar between CPAP and dental devices. So, and of course, the patients did seem to prefer dental device compared to CPAP in this particular study as well. So it confirms many of the data points and questions that we were thinking about. And the conclusion of this study, which is the first time I've ever seen this sort of statement made in a medical journal, was that mandibular appliance splint treatment may be an acceptable choice for first-line treatment in patients with mild, moderate, and severe sleep apnea. So it's quite a statement at the time. In those patients who are, of course, willing and eligible to use the mandibular appliance splint. I should point out that this was a short-term study, just a month, and long-term outcome studies are still needed to convince more people that that might be the case in the long term. What about safety? I think safety is an important issue, and often we are concerned about TMJ and occlusal changes. And I guess I should apologize because I'm speaking to a group of experts about this, and you probably know a lot more than I do about the effects. But I will say that reading the literature, it seems that occlusal changes are usually minor. They're usually subclinical, and typically do not cause the patient to stop treatment. Also, in terms of TMJ dysfunction, there's more and more evidence today, whether you talk to Jameson Spencer or some of the other TMJ experts, that long-term side effects on TM joints are minimal. And there's actually some evidence that if you have TMJ pain and discomfort, mandibular appliance by moving the mandible forward could actually relieve some of those symptoms as well. So there's some good data that certainly from a physician education standpoint, I would say we're on very safe ground if we say, look, if a patient has TMJ pain, let me assess them and see if the patient is a candidate or not for an oral appliance. Certainly temporary side effects are pretty common, salivation, dryness, tooth pain, gum irritation. And I usually reassure my patients that, hey, most of these will resolve in the next few weeks, and just stick with therapy and maybe a gentle protrusion with a slower time frame. It may be necessary for some patients. So that much is the case. Lastly, economics. I think when we think about economics, obviously CPAP is less expensive to start with, but of course there are supplies and masks and all kinds of things that go on over a period of time. So if you compare the 3-year cost of the dental device and CPAP, then they're not that dissimilar. And certainly having CPAP in on the top shelf of your cupboard is certainly not very cost effective. But asking the question in a different way regarding cost effectiveness, and this was a study done in France very recently, actually. And I point out this study because it's extremely interesting, because what the question they asked was, is it cost effective to treat mild to moderate sleep apnea with a dental device versus CPAP in patients who do not have cardiovascular disease? So that was their question. And a little bit of background might be of interest to you. In France, dentists were not reimbursed when they did dental devices. So the uptake of dental devices was very, very poor. And what they found at the end of this study, and I won't go into the details of the study just because of time constraints. But if you look at the highlighted text in red, what they found is, at least in France, it is efficient to treat all patients. And when we say efficient, we're here meaning cost efficient. It is cost efficient to treat all patients with mild to moderate sleep apnea and high cardiovascular risk with CPAP, true enough. But for mild to moderate OSA with low cardiovascular risk, dental devices are more efficient than CPAP. So in fact, today in France, if you have mild to moderate sleep apnea, dental devices are first-line treatment. They are not used after CPAP. They are used as first-line treatment, which I thought was a really interesting, and France actually changed its monetary policy for dental devices based on this particular study. So I thought it would be interesting to highlight that. So I think, of course, this is not an exhaustive review of the literature, and I can certainly share many more studies and many more pieces of information if people are interested. But at least it'll give you an overview of some of the arguments you can make with your physicians and the conversations you can have with them to balance the dialogue in somebody who is extremely skeptical. So when we think about, physicians, it's important that you understand there are some physicians that are aware and open and very acceptable for dental devices. And I would encourage you to find them and work with them, because it'll be a pleasure for both sides. I can tell you that I absolutely value the dentists that I work with, and I take their opinions very seriously, when we collaborate. There are physicians that are unaware of the data or unaware of some of the problems that might occur one way or the other. And knowing the literature and having, the evidence we discussed is important. And I would encourage you to engage them in those conversations. Some may be unconvinced, and, you can use some of the data we talked about and share it with them if they're open. But then I must admit that even in my own experience, there are physicians that are just closed-minded. But they're not going to be sending you patients back, and it can be an admittedly frustrating exercise. And so, which is, of course, one of the reasons why I started the telemedicine practice that I have, where, we can still get the patient on treatment when you come across somebody like that. But think about expanding your referral sources. As you're starting out in dental sleep medicine, certainly, sleep physicians probably see the vast majority of sleep patients, or at least make the vast majority of diagnosis. I shouldn't say see this most patients, but they certainly are, they funnel, all of the diagnosis is funneled towards sleep MDs. But remember, there are primary care physicians, there are cardiologists who see atrial fibrillation and left ventricular function all day long. That has a high incidence of sleep apnea. Endocrinologists that see diabetic patients. There are anesthesiologists who have patients on their table day in and day out. And as soon as the patient gets sedated, boom, the oxygen saturation falls. These are all sources of referrals for you. And I think that cultivating those relationships and looking for those expanded sources of referral is very, very effective. Certainly going to your sleep centers, many of the technicians and sleep managers might be fairly open to referring patients who come into their offices. And many times patients will come into a sleep center and say, look, I don't want CPAP, period. And so they would love to have places that they could refer to for those types of patients. Try CPAP and DME companies as well, because they too have patients that return their CPAP and say, now what do I do? And they typically shrug their shoulders, say, I guess you have to go back to your sleep doc and discuss it. But if they have a ready and available referral source in you, and they have some confidence that you do a good job and take care of the patients well, they can certainly be good sources of referral too. Think about other dentists. I think that as you gain a reputation and expertise in the area of sleep medicine, there are many, many general dentists out there that would love to be able to send their patients for more expert management. And they could be referrals for you as well. And then, of course, when you start your own sleep practice and you're starting out, remember your own patients, your own relatives, your own staff members. I think it's extremely critical to start doing devices in the first bit, because the more you do them, the more confidence you're going to have, the more you're going to learn. And the ability to take yourself from 0 devices to 10 or 50 devices is absolutely critical when you start thinking about expanding your practice and going out and winning confidence for other referring physicians. In terms of building physician relationships around you, I think if you can get a personal meeting with a physician, I think that is great. I know that it can sometimes be difficult because physicians are busy and you're busy. All of you have very, very busy dental practices. And as you start transitioning towards sleep, getting a personal meeting is very effective. If you and your physician both know somebody in common, that is a good start. I've found that places like LinkedIn and Facebook actually are pretty easy. When people have their downtime, they'll be looking on their LinkedIn profiles and say, I got a message from this. Who is that? And that's a pretty good way to use social media. Demonstrate your long-term commitment to dental sleep medicine. I think as a physician, I can certainly say that, we want dental partners who are going to be practicing sleep medicine for a long time and are not interested in just sort of a one and done type, device. We want people that are going to see our patients, send them back to us for consultation, and have a collaborative relationship long term. So if you demonstrate your commitment to dental sleep medicine, that will go a long way. When you see patients in your own office, try to send them for diagnostic testing to the physicians. I think there is this tendency, at least in some areas, where dentists are doing their own diagnostic testing, and whether I support that or not is completely a separate issue. What I will tell you is that if you do your own diagnostic testing and the physicians in your area recognize that you're not sending them referrals when you can, that is just something that is not going to be a confidence builder. So I would say that at least, try your best to collaborate. Let them do the testing and you do the fitting, and that's how things work the best. Always refer the patient back after oral appliance optimization as well. So if a physician or referring source sends you a patient, make sure that you're sending them back for efficacy testing. It certainly is part of the guidelines, and again, helps build trust that you're actually managing this patient and not just fitting a device. Over communicate. I can't emphasize this. I recognize that this is difficult. So when you see a patient, writing a letter or a note to the physician and expecting the physician to write back to you is great, and it does happen many times, but oftentimes it doesn't. I mean, you have a busy practice, so do they, and you don't share the same electronic medical records, so when he gets a letter, he probably doesn't remember who the patient was, and so they don't write a letter back. But it never hurts to continue to try and send letters and communicate as much as you can, because ultimately the patient is in the center, and we need to make sure that the treatment is coordinated well.
Well, yes, if I could pipe in here,
yes.
That is, as much as medical billing is, it's one of the main tools of, main reason to use your dental writer software properly.
Mm-hmm.
Because if you can send that screening report to the physician, even if it's not the sleep physician, but maybe the patient's primary care or cardiologist, that really gets the word out that you're serious about this. And also be sure to utilize your dental writer for follow-up reports too, to show the outcomes. So that helps a lot.
Thank you. I appreciate that. I think that another tip I would say is get a network when you can. Now, with commercial payers, it's often very difficult. It can take months, and I recognize the challenges and difficulties there. But maybe try to get in with Medicare. Lots of physicians have patients with Medicare, and they don't know where to send them because nobody is billing Medicare, for dental devices effectively. So that would be something. I know Nierman Practice Management can help you with some of these strategies as you start seeing more patients. One of the very effective strategies I found is to ask your patients who are happy with you to send letters to the referring physicians. Because I will say that, getting a letter from a referring dentist is one thing, but getting a letter from your own patient praising that dentist is actually quite an eyebrow raiser. And I have received letters, and I'm very impressed when patients write back to me and say, hey, Dr. Smith did a great job, and I'm feeling so much better now. It's going to make me want to refer more patients in the future. And then attend staff and educational meetings as much as possible and whenever you can. I think never stop learning. And when I say that, you should think about fellowship programs. Nierman has a mini residency. Certainly start thinking about participating more formally in these programs. And then be visible in society meetings as well. Not only the American Academy of Dental Sleep Medicine, but there's state sleep society meetings, which are excellent venues to network with your local physicians as well. Some do not advise, I'll share with you, and we've already talked about try not to do your own diagnostic sleep testing. I don't think that's the best idea. And And I recognize that may sound self-serving, but I really mean this from the point of view of developing a collaborative relationship with your local physicians. Second is, don't treat every referred patient with an oral appliance. I actually really respect my dentist when they send the patient back saying, hey, Jagdeep, I don't think this patient is a great candidate because of, XYZ. Maybe it's periodontal disease that I didn't recognize. Or there might be some anatomical issues that, I certainly am not as much of an expert as you people are. So I think having, recognize that you are the expert. I'm sending this patient to you for an opinion as well as treatment. So having that is an important thing. Don't forget that there are other sleep disorders that may need to be addressed. So once you finish fitting your device, if the patient is optimized and the patient is still sleepy or is still having problems with a parasomnia or something, make sure that you address those issues and send them back to the physician so that there's other things that can be taken care of in terms of their sleep management. I would say do not discourage your patients from effective CPAP treatment. If somebody is doing well on CPAP, it's not a good practice to say, hey, this dental device is going to work better. And I'm sure most of you don't do that. But when a physician has a patient who is extremely compliant and well treated, and then comes back saying, well, I decided to go with the dental device and it doesn't work as well, that can certainly be a cause for concern. And don't forget efficacy testing, especially when the patients have moderate to severe sleep apnea, because we know there is some individual variability. And when you send the patient back for efficacy testing, it certainly means that you care about this patient's outcome and not just the treatment. A couple of other thoughts. Dentists and physicians are used to different health outcomes, right? So physicians are very comfortable with, the blood pressure. So yeah, it's better, but not quite better, great. I think dentists want perfection. When you do a cavity filling or when you do a crown, it's just perfect, right? It's art, actually. But with sleep apnea, it's not like that. I mean, if your apnea index goes down from 30 to 15, that's a good outcome, guys. You've decreased this patient's apnea burden by 50%, and he's not tolerating CPAP anyway. I mean, you've done a good job. So remember that, be confident that, you don't always have to achieve perfection with the AHI. Physicians are overburdened and often resistant to change. Science changes slowly, and physicians are not particularly entrepreneurial. So don't feel discouraged. There's lots of physicians out there. You'll find somebody who's going to work with you, and just keep at it, because you are honestly going to change so many people's lives positively by entering sleep medicine and staying in the field. One thing I'll tell you is that physicians have no idea what dentists do. If you ask a physician to name 4 types of dental devices, I would be pretty surprised if you're going to get physicians that will tell you accurately what those devices do and how they function. So, use that opportunity to educate your physicians. When you visit them, carry a few dental devices with you, and they'll be quite interested to see and learn what you do as well. The mindset of employed and independent physicians is not the same. Certainly independent physicians might be able to sell CPAP, for example, and so now that's going to be more of a motivator for them, which is unfortunate but true. So think about some of those factors as you're interacting with them, and be mindful of some of those factors, which you may or may not be able to change in some cases, but at least it'll give you an indication that, hey, it's not something that is the matter with you, but it's just factors that might be outside our control. And lastly, again, communication is absolutely the key. And I think, for me, the value that Nierman brings with the electronic medical record is incredible, because when you enter the field of dental sleep medicine, the frustration is you have to document correctly to get reimbursed, and you will not get reimbursed without all of the, I'll say, items. And plus, making the communication back and forth with the physician also becomes seamless. So to me, that's a huge value add when you're starting out a sleep medicine practice. So screen your own patients, make a few devices, think about using telemedicine, which is if you don't have strong established relationships in the community. I can certainly talk to you about that at another time if we get the chance. Consider being in network. We've talked about become a Medicare DME provider. Consider a third-party electronic medical record and billing solution. initially, especially if you have not worked with medical insurance. It can be daunting. And so find people and partners that can make it easy for you and start down the pathway to becoming certified. Learn, learn, learn. I mean, I would say that is a big take-home message. So here's some resources for additional information that I'll leave with you that you can see another time. And just a couple of plugs for some upcoming Nierman seminars. I think I'm presenting at some of these, but there's a dental sleep and pain conference in October in Fort Lauderdale. Being in Minnesota, I was extremely happy to be invited because October is when it starts getting cold in Minnesota. So
starting to get cold.
Thank you, John. Thank you, Rose.
You're welcome.
And then there's another seminar coming up more imminently, September 6th and 7th, their mini residency. And, that's another great way to keep connected with learning. And that's the last slide. So information about their other conferences. So I'll stop here. I apologize that I sort of haven't left a whole lot of time for questions just because there's just so much material to cover. But I'm pretty passionate about this, as you might have been able to tell. So I'm absolutely open to getting emails and responding to questions later as well. But I'll hand it back to Courtney. If there's anything I can address now.
Yes, thank you, Dr. Bijwadia. That was just excellent. So well presented and well worded. So thank you. For those of you on the line, if you have any questions, please feel free to submit them into the chat box or to the Q&A box, and we'll get those over to Dr. Bijwadia here. As he had mentioned, if any of you are looking to enhance your education, we'd love to see you at that upcoming mini residency. You'll see listed there at the screen, September 6th and 7th. Space is limited. We like to keep a nice tight group there. So this is a four session, 64 hours of CE credits. Dr. Mayor Patel and Dr. Terry Bennett will be the main speakers there, but you'll get to see Dr. Bijwadia again as well. There'll also be some other physician speakers, an ENT, as well as an RPS GT. And there's a lot of hands-on that happens in the mini residencies, so it's always a great opportunity. Not only do you get 2 appliances to make, for the dentist, but you also get the opportunity to shadow an AASM accredited sleep lab, just to see exactly what your patients experience there at the sleep lab as well. So if anybody is interested in more information, or you're ready to get signed up for it, you can always feel free to give us a call there or email, or you can register online at niermanpm.com as well. So if you can't make it to that mini residency in September in Atlanta, Dr. Bijwadia also mentioned our user conference and sleep and pain conference coming up in Fort Lauderdale. So that'll be a nice warm weather break. So with that, we do have actually more of a comment here in the chat box, that when you had touched on the occlusal side effects, that Dr. Wartell mentioned that occlusal side effects are not as important as sudden death or all the other effects of OSA. So I think we tend to agree with that one. Thank you, Dr. Wartell.
Absolutely, no doubt.
Dr. Bijwadia, you had mentioned that you enjoy that increased communication with your dental practices or dentists that you work with and refer to. Mm-hmm. Are there any other factors that you look for if a new dentist approaches you looking to form a relationship?
Yeah, so I would say that oftentimes I'll get emails from somebody who's new in the community, and I would say the most effective thing is to try and lean on another relationship. So if I'm introduced to somebody by somebody else, it's a little bit more likely that that is going to end up in a meeting. I'll say that, right now in this seminar, I was actually very happy to get an email from one of the dentists in Minneapolis here, in St. Paul, and said, hey, Dr. Bijwadia, how about we get together for dinner? And I'm going to respond and say, absolutely. So I think taking initiative like that and saying, hey, can we meet and have lunch or dinner together, and then express the desire to sort of continue collaborating long term, is how I would do it.
Wonderful, thank you. I'm getting a few questions here related to being able to view this presentation again, or share it with your team members. So yes, we do have this session recording, and as long as you are registered for the session, we will send you a link to the recording that you can view and share with your colleagues. For any of you dental writer users out there, the session will also be available 24/7 in the Dental Writer Help Center.
Great.
Okay, great. Well, thank you very much. It looks like that's all the questions we have for this evening. So again, Dr. Bijwadia, we appreciate you taking the time out of your Tuesday evening to educate us on this topic, and looking forward to seeing you at the upcoming seminars.
My pleasure, absolutely, and thank you everybody for your attention.
Thank you so much.
Okay,
it was very informative.
Great. Thank you.
All right. Good night, everyone. Thank you.